Thank you, Saad. That's a very nice introduction. And thank you for inviting me to speak at this very nice conference. Congratulations. So, my task is to talk about surgery and about inflammatory bowel disease, for inflammatory bowel disease. But, Dr. Mohan started with some history, so I always like to start with history too. So, inflammatory bowel disease is increasing in frequency, particularly Crohn's disease. But we've actually had a president who had Crohn's disease. Does anybody know? You got it, Dwight Eisenhower. And in fact, between his role of head of the armed forces in the Second World War and his presidency, he had surgery. Before the biologic era, surgery was very common for Crohn's disease patients. Up to 90% of patients ultimately needed surgery. Interestingly enough, the surgery that they did for Eisenhower was something that's contraindicated today. He had a long section of stricturing disease, and instead of removing it, they performed an internal bypass, which is contraindicated because you can't survey that portion of the intestine for malignant degeneration, et cetera. Anyway, so really when you're talking about surgery for inflammatory bowel disease, you really have to divide it into pre-biologic era and post-biologic era, like as Dr. Mohan very nicely stated. So it really is before 1990 and after 1990. So in the biologic era, we've noticed that for ulcerative colitis, the 5-year probability of surgery decreased significantly, over 60%. There's a 10-year risk that also decreased by 50% for surgery. Urgent surgeries also decreased from 21% to 14%. And elective colectomies also decreased. For Crohn's disease, the 5-year probability also decreased by 30%. And patients with hospitalization required surgery less frequently. The annual bowel resection rate dropped from 12% to 6.9%. So significant decreases in the need for surgery. And these trends are consistent across the United States, Asia, and Europe. There's also been an evolution in the type of surgeries that we perform. So there's been a shift in Crohn's disease towards more bowel preservation, more segmental resections instead of total colectomies. There's an increased focus on stricturing disease that is now making up almost a third of the procedures being performed. Also, laparoscopic and minimally invasive procedures are now being done in more than 2/3 of the cases of Crohn's disease. Nationally, 8 to 11% of these procedures are done robotically. At VHC, over 80% of these procedures are done robotically. Also, we've noted a significant decrease in the stoma rate. For ulcerative colitis, on the opposite side, there's less of a trend towards partial colectomies, and we are moving towards total proctocolectomy and trying to do a restorative ileopouch formation. Again, here, laparoscopic approaches over 2/3 of the cases. About 10 to 15% of these cases are done in the United States robotically. When you do a minimally invasive surgery, there's a significant reduction in complication rates. And again, the standard operation for surgery for ulcerative colitis is a total proctocolectomy with restoration. So the indications for surgery have also somewhat changed with biologic era treatment. The main indication for Crohn's disease is fibrostenotic disease and fistulizing disease. Ulcerative colitis, there are emergent cases, which are decreasing, thankfully, but toxic megacolon, where the severity of the inflammation degenerates the nerve plexus in the wall of the gut. You get paralysis, and then you lose barrier function, and you have sepsis. Perforation, severe bleeding, and organ dysfunction are also causes of emergent surgery. The more common reasons for surgery for ulcerative colitis are medically refractory disease, and also neoplasia and dysplasia degeneration. It's important to note, though, that the American College of Colorectal Surgeons' statement is that surgery is not considered a failure of treatment. It is an integral part of the treatment of inflammatory bowel disease. Timing of surgical intervention. So a lot of concern was raised initially about the immunosuppressive effects of biologic treatment and what would that mean for surgery going forward. So certainly there's a greater emphasis on maximizing medical therapy first. Early biologic therapies did increase surgical infection, particularly Remicade, with an overall risk ratio of 0.63%. But in Crohn's disease, if you have early initiation of the biologic therapy, you have a better outcome long-term and reduction of need for surgery. Paradoxically, with ulcerative colitis, early initiation of biologic therapy has seen an increase in the need for elective surgeries. And I think that's probably because of the severity of disease and the outcomes, because typically ulcerative colitis patients are still treated with mesalamine products. And so if you're going early to biologics, I think that's skewing this. Also importantly, when there is a delay in surgical approach in severe ulcerative colitis patients, the complications are certainly decreased. So as far as safety of anti-TNFs, there is a very minimal increase of infectious complications. The absolute risk increase is 5.5%. Which the number needed for harm is about 18, so not a significant increase in risk of these, with these products. So, but we also have very limited data on this, especially with the newer agents. So a couple of these agents that are newer, I'm not going to try to say this, but the first one is Entyvio, the second one is Stelara. Entyvio does have an infectious risk similar to Remicade. It does have a particular issue with postoperative ileus. And Stelara, although preliminary data shows no increased risk, it's still early to tell. The main problem with the medications that are used for IBD are the steroids. These are certainly increased not just infectious risk, but multiple other perioperative complications. And we try to wean the steroids prior to surgery to at least below 20 milligrams a day. Immunomodulators don't really increase surgical risk. So the principles of perioperative management, I don't really stop biologic therapy prior to surgery, maybe a dose to have a 2-week window, but it's not a significant issue. Very important is to manage and optimize the nutritional status of the patient. This is frequently overlooked. These patients come to surgery obstructed or with significant disease, and they are malnourished, and so this has to be a primary concern. Therapeutic drug monitoring is also something that's being done more and more frequently to assess optimal levels of medication, and this is going to be an important role in trying to optimize the patient prior to surgery. And again, essential is the collaboration between the surgeon and the gastroenterologist to maximize the patient's outcome. So selection of the patient for surgery, chronic refractory disease, which is unresponsive to optimized medical therapy, is a very common presentation for ulcerative colitis in particular. For Crohn's disease, the Lyric trial and the Swedish study showed that upfront surgery for short segment obstructed fibrostenotic disease actually shows improvement in clinical outcomes long term. And then you have to get off the steroids. If they cannot, then certainly that is a surgical indication. And then you have to consider the characteristics of the patient themselves, age, comorbidities, nutritional status, et cetera. In the immunosuppressed patient, a staged approach would be indicated. So With all of these considerations, also adding an ERAS protocol is fundamental. The 30-day mortality rate is declining significantly, where in Crohn's disease it's between 1 and 1.5%, and ulcerative colitis that has decreased to just a little over 2%. There is certainly a shift towards elective procedures in both Crohn's disease and ulcerative colitis. The benefits of minimally invasive surgery are well known, with lower complication rates and reduced stoma formation. These are just indications for emergency surgery, perforation, toxic megacolon, hemorrhage, multi-organ dysfunction. And this is again stating the improved outcomes in the biologic era. Interestingly, though, there is an issue of recurrence, particularly in Crohn's disease. We are doing organ-preserving surgeries, and so the risk of recurrence used to be around 70% after surgery. With biologic therapy, that has reduced, but it is still fairly significant. 1 in 4 patients will have a recurrence. So beginning biologic therapy shortly after surgery is fundamentally important. But postoperative biologic therapy does reduce long-term recurrence by a factor of almost 6. And patients' satisfaction is certainly increased if you can do a minimally invasive surgery. Long-term outcomes are generally favorable, particularly as far as functional and quality of life. There is an improved surgery-free survival. There is almost a 0 5-year surgery risk after a resection and biologic therapy initiation. As far as long-term outcomes for pouch procedures, there's about a 6% lifetime failure of the pouch, where the pouch has to be removed. And pouchitis remains the most common complication after a pouch procedure, which is about 30%. And then, of course, disease recurrence, particularly in Crohn's disease, remains an important factor. And again, the most important thing is that you have a patient-centered, multidisciplinary approach to the care of these people. Cost-effective considerations. These biologic agents are quite costly, and several studies, particularly the Lyric trial, has shown that it is cost-effective to do upfront surgery for fibrostenotic disease. I think that as we move forward and we come up with more biosimilars for the biologic agents, costs will come down and efficacy will improve. Limitations. Most of our data is from retrospective or observational studies. There are many indications for treatment and surgery, and this varies not only geographically, but also from individual physicians. So optimal timing and dosing has to be standardized. Regional variability with practice patterns has to be more homogeneous, and we need more controlled trials, prospective controlled trials with focusing on surgical endpoints. I think going forward, to improve our outcomes, we need to better define patient selection criteria, optimize treatment sequencing, incorporate real-world data from the rest of the world, characterize risk factors perioperatively, and then improving education, particularly with physicians as well as patients. And we need long-term quality of life studies. Key takeaways. Biologic era has reduced surgical rates significantly. There's been a shift towards bowel preservation in Crohn's disease and minimally invasive procedures. Biologics are safe in the perioperative period with only a modest infectious risk. Surgery is an integral component of the multidisciplinary care of the patient, and there are improved outcomes with lower mortality and complications. Ongoing research, of course, is still needed. Thank you.